Thank you, Anna. Very, very nice. And could I have all the panelists come up? We're going to take 10 minutes only. And while they're sitting, Anna, did it make any difference in your groin pain group whether they're kicking on with the side of the groin pain or?
Nope. Some of the players, we did record that. Some of the players had the pain on the dominant leg, and some of them had on the non-dominant leg. Some of them had bilateral pain. Did not seem to make a difference, interestingly enough.
I think it's time to open the discussion up to the audience. Yes, sir, in the front row, or the third row. Do we have a microphone?
It's a question for Christian and for Bears. Again, thanks all for the very nice presentations. I think you showed one slide that showed that with adductor-related groin pain, that the concentric strength was the same in the groups with groin pain and without groin pain, but then the eccentric strength was pretty much less, significantly different. And in your last slide, you said about 25 to 50% of the people who are treated with exercise, they don't recover after a year. So my question actually is, should we increase the amount of eccentric training in the adductor-related groin pain treatment?
Not sure if I get the question, but it's true that it was an isometric, no deficit in the isometric, but there's an eccentric deficit. These are football players coming in and showing these differences, and in the study with that Per did, there was a lot of footballers as well, but they've been off for a long time, so they're not completely comparable in that sense. I think you need to in the cross-sectional study, 70% of these players were actually playing but coming in with problems, whereas the other ones has been out for more than 2 months, coming in doing an adductor-related program. I think there's a difference. I think in those I would be quite certain you would also see isometric differences. I think they would have more deficits in general. So I would be a little bit careful by saying that they should just do more eccentric for those who didn't get well. I think they actually got quite a lot of eccentric training in that program, and we also know that they complied really well in Per's program. But maybe it would be interesting to have the measure on them, and maybe you could have seen a difference in the study of Adam and the study of Per, that they actually didn't reach that eccentric adduction strength. Maybe, yeah, because they didn't do enough training. That's just a hypothesis. I have no data to support that, but could be an idea.
So when you think, okay, how can we increase the level of the people who are satisfied with the exercise treatment? Already it's pretty high, but do you have any suggestions how we could possibly make that higher?
Higher than 80% or higher than 50%?
50.
I see 3 questions. Oh, did you answer a question?
No, we can. Is it okay? We move on. Can we take that afterwards?
That's fine.
I see 3 questions so far, and so we're going to try to limit the question words and the answer the words of the question. So Tim, next.
Good morning from New York. I tweeted my question because I knew this would happen.
It sounds like you're tweeting now.
John, can you help me? Right there.
How do you know if the tear will heal with rehab? A sports hernia, sportsman's groin.
To our surgeons. How do you know that?
Yeah, well, what degree of certainty do you have that it's going to heal with the rehabilitation program?
For me, how I know that it heals? Yeah, I know it because the pain will disappear and the player will go again to sport activity, usually after 1 month or 2 months. Of course, we make some physiotherapy after operation, but usually it's no need because the patient will heal when the wound is healing and all these tissues are healing. So it's simple. Surgeons are simple.
And he wants to know, what are the key issues with the rehabilitation that will make your outcome better?
Can you
repeat it, please?
What are the key issues to rehabilitation? And I suppose one of the things, perhaps I'll just add to that, is if you've got a surgical technique that's going to get a patient better in 10 days, why wait 8 weeks for rehabilitation? If you've got a sportsman that can't play because of a sportsman's hernia.
Okay. This technique which I did introduce is the one that you don't cut sound tissue, that you don't enlarge the defect, that you only repair the small weakness of the posterior wall without cutting any sound tissue. And in comparison to the laparoscopic technique, you get a big area of wound area because of the big mesh. And this mesh has to heal and has to grow in, and this is causing a lot of scar tissue. So, of course, I get scar also if I do the minimal repair technique, but I keep the slight bearing, and the scar is as less as possible because I don't cut any sound tissue.
Rodney, I think you had a question.
I answer very shortly. I think that you are very successful if the players can go after 10 days or 2 weeks to field again. I think that after surgical wound, it takes minimum 3 weeks, 4 weeks to recover, and we don't need any rehabilitation. Just the wound healing is the key factor, and it's individual. Some patients, some people, it can happen in 2 weeks, but usually it takes 3-4 weeks.
Rodney? Yeah.
Anna, thanks for a great talk. The most amazing part for me was that nobody's thought to look at the change in kicking kinematics pre and post getting groin pain. If I read your phase plane graphs correctly, it looked like a past history of kicking made people essentially behave more stiffly. They were reducing their amount of movement. What implications do you think this might have? Because we've seen the same thing in the ankle and at the knee after instabilities. It's very fashionable to do core stability type exercises which aim to reduce movements down to even isometric, and it looks like the right way to go is to actually have a large range of motion.
Yes, that was one of the things that we noticed as well, that it seems like when changing the approach angle to 60 degrees, the previously injured group still tried to kick as they kicked from 45 degrees. I'm not exactly sure what we can do, but I do agree with your way of thinking that I think we need to, because these players are currently healthy, but they're trying to adapt it into their own, utilize the same kinematic patterns, whichever angle they kick from. So it might be a better idea to try to make them feel comfortable across larger ranges rather than just because they have that very narrow field where they feel comfortable moving. And it might be a really good approach to try and widen that, to actually help them be able to adapt to when they get put into situations that they can't handle.
We have a question in the middle and then up at the top there, in the middle here.
Hi. So first of all, congratulations for the talks, very interesting. And it's a question for the whole table. Saying how different etiologies can we have and sources of pain in groin, the different or the information that we have from imagine symptomatic and asymptomatic patients, we can have the same injuries in both patients, and the results from conservative and surgical treatment. The question is, when should we send our patients to the theater, and how long should we wait, and even what you do in the surgical theater? I know we are talking about the sports hernia, but we should think about how many structures could we or should we treat. Thank you.
Yeah, I can start. I think I can only talk for the adductor related, but if we consider that many of them have that aspect as well, I would say that I wouldn't call it conservative treatment. I would say if they fail the exercise-based treatment, then you can consider other treatments. I think one of the main issues, though, is that they're getting asked whether they have done the exercise-based treatment, and by a surgeon maybe, and they say, yeah, I've done it. But when you actually ask them, they've only done it twice or came 3 times for 4 weeks, and then they decided not anymore. So you definitely have to fail the exercise-based program. Then you might even consider to test them as well. So you might consider to test how they're actually doing on the Hagers, how are their adductor strength, how are their, if you have any other measures of their performance or stability, because you want to see what. Also, you need to relate that to the surgery that you're going to put them through. But I would definitely make sure that they've sort of failed the real program.
Christian, are you talking about more chronic pain type things, or
yeah.
You're excluding
these are the long-standing ones, yeah.
Okay. Question up here.
Rob Langhout from Holland. Anna, thanks for your research. I have a question. Did you instruct your football players to kick with certain velocity, maximal, or just free to kick, whatever you want?
We had a target placed out in front of them. We had a Kevlar net in front of them with a target marked out of approximately 1 meter wide target. So we did instruct the players to hit as hard as they could, but they had to hit the target. So adding that little element of accuracy probably do force them to decrease the velocity a little bit, but we had the criteria that they had to hit the target for the kick to be valid.
And do you know what was the compensation mechanism so they could shoot as hard as the other group?
We did tell them that as hard as you can, but you
haven't got an idea what was the compensation? They had less range of motion, less velocity on the stance leg?
We did, like I said, we didn't take anything like that into consideration. We simply said, kick the ball as hard as you can. And the reason for this is that we know that there is a lot of difference between static and dynamic range of motion. However, it would be an interesting addition to the research, absolutely. And we were considering doing it, but time constraints for an honors degree made us elect to not use that.
Thank you.
Thanks.
Good. Another question right here.
Thank you. Dr. Tyagarajan from India, Chennai. Biomechanics is a very enterprising area. Our center recently has been accredited by the ICC. Cricket biomechanics is what we are doing. I saw some force plates there on your kicking area. Did you use the force plate data? And what was it saying?
We have collected the force plate data, but we haven't had time to process it yet. We are definitely looking forward to look into everything into this. I don't think when we designed this study that we expected to get such clear results, to be completely honest with you. We do have plans, though, to go ahead with a follow-up study where we're looking at the kinematics and the kinetics involved as well.
Lovely. All the best for your PhD. Thank you.
Sounds great. I'm happy that there's no questions about symphyseal joint surgery or adductor detachments. And I congratulate the panel and congratulate you for great questions.
Just before everybody goes, a couple of housekeeping issues. Those who haven't yet noticed, we've been subliminally brainwashing you all day during the coffee breaks. But now the official pitch, because in May next year it will be the 7th edition of the IOC Advanced Team Physician course. I was a participant and part of the faculty this year for the first time when it was in Mandelieu in France. It's a fantastic conference, and Aspetar is supporting hosting this here next year. So first come, first serve, limited seats. I don't know, is Roald still here? He'll be very happy I gave the plug for him. The buses going back to the Shark Village Hotel will be leaving from 5:30, so we've got 6 minutes to get ourselves to over to the reception area, and then we'll all get on the bus and go together back to Shark. The delegates who are not staying at Shark, you're welcome to join us for the conference dinner tonight. That's going to be 7 o'clock at Shark, and it's on the terrace, the grass near the beach. And for all the people who are staying at Shark, both delegates and faculty, will hope to see you all at 7 o'clock for dinner tonight. Thank you.